The need arose because we were losing more and more resources in the community for our patients. And so our patients were facing more fragmented care. So the thought process was, first, we know our patients, we deal with them, we know their situations, and to add one more person to that already complex care was becoming overwhelming for our patients. We were facing delays, more hospitalizations, and delays in getting patients started on treatment. So the idea after meeting of the minds was, why not just start our own in-home program where we can have a continuum of care? Now, hear me, it wasn't to eliminate the community, but we needed to at least be the first resource. So that was the initial start of the program. And it also started with a select population. So we were only looking at initially head and neck patients, pancreatic patients, breast cancer patients on high-risk regimens, and some of the genitourinary malignancies in lung cancer. That's not to say that all patients wouldn't benefit, but we wanted to kind of start small and kind of bridge out. So we started there and identified key factors that made them high risk and definitely need palliative care services.
Wrapping our arms around these patients, and they're here for treatment anyway. So how can we meet their needs and really have a continuum of care and help them understand we already know half their story. Let's take that next step and meet their needs, and also identify risks before they happen. Because as we evaluate these patients, we can do some preventative work or teach them and educate them what to look for and how to manage that when they get home, so that they're not calling us 3 days later after they've been already trying to manage it at home. We can do some preventative work.
Now that we've been doing this program for about 5 years, we know that oncology changes at a rapid pace. So this year we began a risk stratification pilot to help not only with our palliative referrals, but identifying patients that need additional assistance. So can you describe what prompted this pilot and this modification of what we've learned in the 5 years?
So it wasn't as simple as just looking at the patient on paper, but having a conversation and looking at the patient from a physical standpoint. So when the patient gets up out of your chair, how long does it take for them to get up out of the chair? Can the patient get from the chair to the exam table and not need you and the medical assistant? So it was so much more than just, I have your history in front of me, but I need to see your history in action. And so we worked to develop a tool that would help us identify key risk factors. It looks at patients' performance status. It looks at, their mobility, their nutrition. It looks at psychosocial factors. Are there nutritional factors that are impacting? Can a patient get a meal? Are they able to eat? Are they able to get chemotherapy and go to a home? Do they have financial insecurities that we need to think about as we begin to treat them? Because not everybody leaves our treatment rooms and they have somewhere to go or can make ends meet. And so we had to look at all these factors in terms of how we can treat effectively but maintain a balance, a psychosocial balance and a holistic balance that includes all these factors.